Hello everyone, this is Dr. Meera from the Part 3 Summit. In this video, we'll be looking at an important station to practice in which the role player is asking for an induction of labor following a cesarean section. At the end of the video, we'll also be looking at how to go about any negotiation station. So let me start by asking you this. If a woman with a previous cesarean section has come to you asking for induction of labor, what would you do? Do you recommend that, or would you insist on a spontaneous delivery or even a repeat cesarean section? So if you're already thinking about an answer, you have fallen into the same trap that many MRCOG candidates do. Because here the examiner isn't testing whether you can choose the right option. It's about whether you can help the patient choose the right option for herself. VBAC, induction of labor, is one of those stations which is about decision making. So let's see how a good candidate can perform the station. The candidate instruction is seemingly simple. The patient is a 36-weeker, she is a second gravida, and she is here requesting induction of labor. The role player instruction seems long, with defined response to any particular candidate question or statement. The key details to note here are: she is here asking for induction because her husband will be going away in 2 weeks' time, and she has another child to take care of. And her previous mode of delivery was a cesarean section, which was done for emergency, and this was due to a failed induction. So these are all the key details you need to elicit. And this patient is a headstrong patient. She wants to be heard. So these are all the details, and she needs to deliver within 2 weeks' time vaginally. Following this information, let us go into the minute-wise strategy we always insist on. Remember, this is not a template. This is just a strategy for you to practice upon. So initially, introduce yourself, you confirm the patient details, and you give an open question why she is here. So let her explain her story. Let her tell the story. The first mistake most of the candidates do is jumping straight into long rehearsed openings. Don't do that. Before setting an agenda, spend a moment understanding the woman's perspective. What exactly is her concern? What is driving her decision? This matters because different women walk into the room with very different priorities. So if you don't understand what matters to them, if you don't ask that question why she wants the induction, your counseling later will sound generic. Sometimes you might as well miss this why question. That's going to cost you dearly. So ask why exactly she needs to be induced. So once you have understood her concerns, the next step is to acknowledge them. A simple statement, something like, I can understand why you thought of this. It's completely understandable. Let me ask you some more questions to know more, so that we will know the other options and also will come up with a safe care plan. So once she says, yes, we can go on, you ask for further key details, which is the next 1 to 3 minutes time in which you get a focused history. The focused history means that you ask the current pregnancy details, any particular concerns during this pregnancy, how the baby is, how the position is. Can you please ask her pregnancy details, go upon where the afterbirth is, how her previous pregnancy and delivery was, what was the mode of delivery for the previous pregnancy, and at the same time, why this cesarean section was done previously, what was the indication, was it due to breech presentation or failed induction. So those details are going to impact the current delivery decision and the success rate of the VBAC. And apart from that, you get the BMI, blood group, allergies, any reservations for transfusion if needed, because this patient can go in for a surgery, emergency surgery, or she might bleed owing to some risks or even due to rupture. So these are all the key details you need to elicit. And one more thing is, you need to ask what are the future plans for her pregnancy, if she has any future pregnancy plans, because that point is going to help you in counseling for a VBAC. So once you get these details, you move on to the major chunk of the station, the 4 to 7 minutes time in which you will be discussing the options and the risks. So here you need to outline all the 3 options: the spontaneous labor, or induction, which she is asking, or an elective repeat cesarean section. You need to be mentioning the benefit and risks of each of this. We will discuss this in detail. So you would need to showcase the VBAC success factors and the uterine rupture risk and what you would do to safeguard her when she's going into the labor. As for the induction consideration, you will be starting with the benefits, if at all needed, for that of induction, and what are the risks associated, and why we would offer this only for those in which there is a particular indication in which the benefits of kickstarting labor earlier is going to outweigh the risks of the induction. So use balanced, clear language and check understanding. The examiner here wants to see that you present all the options fairly. The moment you start pushing one option over the other, you would lose marks. So when discussing induction, start with the positives. Candidates often begin with complications. The patient stops listening the moment they feel frightened. Instead, begin by explaining when IOL is even considered. Of course, IOL is a good option if you'd want to kickstart the labor earlier. There are various methods. You need not mention the methods unless she's asking, because in this station, it's about the overall induction as an option rather than the steps of induction. So don't go into details which are not relevant to the task. So at every diversion point, you ask whether the role player wants to know or wants to listen to this. Then go into the details. So mention all the positives of successful indication for the induction. Only after discussing the benefits, you should be moving on to the risks. Of course, the most important risk is uterine rupture. Now, this is where the candidates often get themselves into trouble. They either minimize the risk completely, or they make it sound terrifying. Neither approach is an appropriate one. So the balanced approach is to explain that the rupture is increased in induced labor because of this risk. It's going to be offered only if the benefits of induction overweigh those risks. So notice that you are not trying to frighten the patient here. So towards the end of the station, many candidates suddenly become rushed around that 7 to 9 minutes time. They realize that the time is running out and start throwing information at the role player. So avoid this. Bring the discussion together. Something like we have discussed various options. My role is to help you understand the benefits and risks. You need not take a decision right away. I'll give you written information of the options after cesarean section. You can go through this. And I'll document whatever discussion we did here. And also I'll book an appointment with a consultant because sometimes she might not accept whatever you said. She might be undecided or she might be insisting on induction. The point you showcase to the examiner is that you don't come to an unsafe decision or you don't thrust the decision upon her. So that is going to downscore in terms of lay examiner, right? So don't do this. What you're going to do is give her time, give her information, book an appointment with the consultant, and also mention the anesthetist appointment with whom you will discuss the pain relief options, the various birth options, and mention the safety aspects in terms of if she has any pain, any leaking or reduced movements, she can come immediately. So if you approach it as a conversation rather than a rehearsed recital, you'll sound more natural, confident, and that's what the examiners are looking for, right? So when you see a VBAC induction station, you need to think, how can I help this woman make an informed decision rather than what to do in this station? Oh, this is a negotiation station. It's going to be tough. So the best way to go about here is to start with her option. Her option is going in for an induction. Of course, induction is the method in which we kickstart the labor before it starts. We have various methods. You need not go into detail about the methods because this is about an induction overall as an option and not about individual induction methods, which is why you need to understand how much information you need to divulge for a given station. So ask, if you are in a doubt, ask the role player, is it something she wants to know more? So you start with the induction here. Of course, this is a good option. If this is successful, you will avoid the surgery and this is going to be associated with early recovery. You'll be able to take care of your baby. But then there are risks as well. If we induce before 39 weeks, the baby is still immature. Baby might have breathing problems. And for you as well, because induction is something we offer only for those in which the benefits of kickstarting the labor is more than that of the risks of continuing the pregnancy. So tell her that this puts you at risk of the scar, where the scar can give way when she's being kickstarted with labor. At the same time, it can fail. If it fails, we will have further options of going ahead with again inducing or going in for an emergency cesarean section. This is not something she would wish for. So which is why we don't offer it unless and until this is indicated. And that is going to be a consultant decision. I know this is difficult, but there are other options as well. Would you like to hear about them? If she insists, I don't understand, but we would need to think of your and your baby's safety, which is why I would need to tell you the other options as well so that you can come up with a safe care plan. The other options are allowing for the labor to come set in spontaneously. So if that is the case, the risk of this failing is less. The success rate is good. Put her individual factors also into the consideration, like her normal BMI and her future pregnancy wishes and the baby's position and the reason for previous cesarean section, and give a success rate for her individual status. And bring in her future pregnancy wishes also into the counseling point. So this is the best because the success rate is good. Of course, this is not without risks. Of course, the risk of rupture is there, the scar giving away is there as well, which is why we will recommend you to deliver in the obstetric unit under continuous monitoring. I know your husband is going away in 2 weeks. We can offer you one-to-one midwife care. We'll be there throughout your labor. And also we have various pain relief options throughout the labor. We will discuss this with the anesthetist who will be responsible for this. We'll have a delivery discussion meeting again with the consultant. So this you can mention. So this, the advantage is that she can have further pregnancies as well, and the risk of delivering vaginally is going to be good. So if she doesn't want this uncertainty, the other option is going to be going in for an elective repeat cesarean section. This completely takes away the uncertainty. Generally, we offer this after 39 weeks of pregnancy because the baby is still immature and there is going to be increased risk of breathing problems. So if you go for this option, the advantages is that you completely avoid the uncertainty, and the risks you need to tell are the immediate risks and long-term risks like the placenta-related problems. And if she is planning for future pregnancy, especially, this is more. So whatever be the decision, you would be supporting it, and you would be giving her time to come to a safe option. Sometimes if she is still undecided, that doesn't matter. You need to demonstrate that you don't come to a decision which is unsafe, and at the same time, you respect her autonomy. So with this, let us go to the domain-wise points which you would need to mention. Most often for this station, candidates might score borderline. Of course, you will not fail if you have had a considerable amount of preparation, because this is a seemingly simple station with certain nuances. If missed, will put you in the borderline score. So if you look at information gathering, if you don't elicit why exactly she is asking for the particular induction, this will be like a borderline. And if you miss out on individual factors like BMI, previous indication, and you don't give an individualized success rate, again, this might be borderline. For the communication with the patient, the most important principle you would need to demonstrate is respecting her autonomy. So just telling her that we respect your wishes is not going to give you scores in this domain. It's how you showcase that. You start from respecting her decision, acknowledging her decision, at the same time offering her options and giving her time to come to a safe decision, at the same time avoiding unsafe options and imposing the safe option on her. So be polite and show empathy, allow her to talk and express her concern, validate her concern, give her options and start the discussion from her option. So if you sound paternalistic, like you should deliver in the hospital, you should not go into induction. So that is going to sound very paternalistic. Use terms like, I know this is not something you would want to hear, but we would like to recommend you to deliver in the hospital because this needs continuous monitoring, because anytime the scar gives way, you would need immediate attention, which might be possible in the hospital. So rehearse on this way. For communication with colleagues, of course, you will involve the consultant in the decision making and you'd be documenting the discussion for future reference and for further planning. Make sure you mention the anesthetist and the midwife, one-to-one midwife care that can be offered when she is going in for a delivery. For the safety aspect, you recognize that she is a previous cesarean section patient and you discuss the safety considerations of the VBAC and if induced, what are all the problems you would need to avoid. And make sure you mention the place of birth. It's also a safety consideration. The applied aspect of the station is demonstrating how you balance the understanding of VBAC, elective cesarean section and expectant management into the station at the same time respecting the patient autonomy. So be patient-centered, have a clear communication and showcase your clinical judgment. So that is the key to the success in this station. So before we finish, let us talk about one of the most important skills in the part 3 MRCOG tasks, that is the negotiation. Many candidates, what they think is negotiation means convincing the patient to accept our plan. That's not what the examiners are looking for, right? Negotiation is about moving from disagreement to a shared plan while maintaining the rapport, safety, and respecting the patient autonomy. So let us go through this flow chart. The first step here you see is to understand the patient's position. Before trying to explain anything, find out why they're saying no or why they have a different preference. Every patient has a reason. It may be fear, a previous bad experience, or it could be misinformation, or simply something has happened to somebody they know, or simply a lack of understanding. So once you have identified this concern, you acknowledge it, validate her feelings. This is where many candidates lose marks. Patients are much more likely to engage when they feel heard. A simple statement like, I understand why you feel this way. This can completely change the direction. The next step is to explore, ask open questions. What exactly worries them? What are they hoping to avoid? Okay. Often the issue is not what it appears to be on whatever they say on the surface. So only after you get this understanding of this perspective, whatever they have, you should be moving on to providing information. So this information needs to be tailored to the concern they have expressed. Avoid long lectures. Avoid detailed discussion. Don't teach the role player. Focus on specific risks, benefits, and options that are relevant to their situation. Once you have shared the information, check understanding. Ask the patient to tell their thoughts or if they're following, and invite questions. So now comes the actual negotiation. Look for common ground. Usually both you and the patient want the same thing, a healthy mother and a healthy baby, right? So emphasize the shared goals and see whether there is a middle ground that respects the patient's wishes. At the same time, you maintain the safety. You need to demonstrate this. If agreement is reached, summarize the plan and ensure that the patient feels involved in the discussion. If not, it's all right. The disagreement remains, it's all right. Don't become confrontational. Reiterate your concerns. Explain the potential consequences. Offer a senior review. And document the discussion. Don't forget to document. Remember, respecting autonomy is a part of safe practice. At the same time, you do not accept whatever unsafe decision she wants. So the key message here is this negotiation is not about winning an argument. Do not be worried if you don't convince her. It's about understanding the concerns, sharing the information, giving her time, and arriving at the safest possible plan together. So if you remember this principle, you'll be able to apply this flowchart to almost any part 3 station, whether it is an induction of labor, a VBAC, or a breech delivery, ECV, birth choices, fetal monitoring, home birth. So that's exactly the kind of professional behavior what the lay examiners are looking for. So with this, signing off. Follow for more. Bye-bye.